Good morning, everybody. My name is Vijay Shivaswamy. I'm an endocrinologist at the Med Center as well as the VA. Today, I'm going to be talking about cardiovascular benefits of diabetes medications. This is my disclosure slide. I'm a site principal investigator for clinical trials funded by Novo Nordisk and Coor Pharmaceuticals. I will be discussing some products by Novo and from other companies as well. My objectives are to evaluate the currently available type 2 diabetes treatment options, to understand the effect of some of these diabetes medicines on cardiovascular risk, and we will be focusing specifically on the SGLT2 inhibitors and the GLP-1 agonists. And finally, to identify patient and disease characteristics to establish appropriate therapy. So, type 2 diabetes is associated with 1.5 to 2-fold higher risk of cardiovascular outcomes or death. And as we're doing more and more cardiovascular outcome trials, we're realizing that heart failure is a huge problem in patients with diabetes. And heart failure is the first presentation of cardiovascular disease in about 14% of the type 2 diabetic population. And there's a 27% prevalence of heart failure in this population, and also based on the cardiovascular outcome trials, we find that it's one of the most common reasons for hospitalization. And the hospitalization for heart failure is nearly as common as non-fatal MI in most cardiovascular outcome trials. And type 2 diabetes is comprise about 45% of the cases of chronic kidney disease, as compared to hypertension being 28% of the CKD. So here we have summarized the impact of intensive therapy for diabetes. Now, keep in mind that this does not include the trials assessing the effect of the SGLT2 inhibitors and GLP-1 agonists on cardiovascular outcome trials. That comes a little later. But what do we know before that? The UKPDS was a trial, a randomized controlled trial in patients with new onset type 2 diabetics, comparing the conventional therapy to intensive therapy. And what they found was at the end of 6 to 7 years, having an A1C of 7% as opposed to 9% reduced their microvascular complications. And when they prolonged that study by 7 more years, that continued to show a reduction in microvascular complications, and also it showed cardiovascular benefit and mortality benefit. So the importance of this study is that when you see your patients with new onset or diabetes, type 2 diabetes in the early stage of disease, it's really important to consider intensification of treatment, as they not only have benefits short term, but they may have benefits long term. On the converse side, when you look at patients who had type 2 diabetes for a longer time, say 10 years or longer, and these trials show that even controlling them, less than 6.5% compared to 7.5% A1C, did not show benefit in terms of cardiovascular disease or mortality. In fact, one of them actually showed increased mortality. They continued to show microvascular benefit, and this is why it's really important to emphasize intensive control early on. And so that's why the ADA has the individualization of glycemic targets. When somebody has a low risk of hypoglycemia, newly diagnosed diabetes, and have a long life expectancy, and this absent vascular complications, you can target their A1C to 6.5 or lower. And the most commonly used metric is a less than 7%, but you can go lower in these kind of populations, or maybe become less stringent on the other side of the equation when you have a high risk for hypoglycemia, or they have long-standing disease duration, short life expectancy, a lot of comorbidities, and so on and so forth. So when you look at what causes hyperglycemia, you have a variety of factors, um, including the reduction of pancreatic insulin secretion, increased glucagon secretion, you have decreased peripheral glucose uptake, decreased renal glucose excretion, you have increased hepatic glucose production, you have a decrease in creatine effect, you have decreased gut and carbohydrate delivery and absorption, and potentially some unknown causes yet as related to the brain. But we do have therapies that are addressing all of these mechanisms, such as insulins, you have glycinides, sulfonylureas, amylin mimetics, which address the pancreatic portion of the equation. You have dopamine agonists, such as, if you didn't know, bromocriptine, long-acting bromocriptine has been FDA approved for type 2 diabetics. Especially it has a predominant effect on the postprandial blood sugars, but we seldom use it due to side effects and cost. TZDs are also available. Currently, only one TZD is in play. It's a pioglitazone. And then this is one of the more exciting classes of medicines. Those are the sodium glucose-like transporter 2 inhibitors. And we have the metformin and bile acid sequestrants addressing the hepatic portion of the equation. And then you have the incretin mimetics, the GLP-1 receptor agonists, which is what will be another drug class we will be focusing on. And then you have the DPP-4 inhibitors and then the alpha glucosidase inhibitors as well. So just so we're all on this same page, so let's review the effect of GLP-1s in humans. So GLP is glucagon-like peptide 1. What happens is after food ingestion, this GLP-1 is secreted from the L cells of the jejunum ileum, so which in turn stimulates glucose-dependent insulin secretion, and which is why there's a very low risk of hypoglycemia. And it suppresses glucagon secretion, slows the gastric emptying, and leads to reduction of food intake. So these are some of the currently available injectable GLP-1 receptor agonists. You have exenatide, lixisenatide, liraglutide, exenatide ER, dulaglutide, and semaglutide. Now all of these are FDA approved as an adjunct to diet and exercise to improve glycemic control in type 2 diabetics. Some are short acting, some are longer acting. Now, to emphasize a little more, the liraglutide not only has the glycemic control indication, but it has the indication to reduce the risk of major adverse cardiovascular events in patients with adults with type 2 diabetes and cardiovascular disease. And similarly, semaglutide has the indication to reduce risk of major adverse cardiovascular events in type 2 diabetics with established cardiovascular disease. Now, dulaglutide, I'll show you the trial data later, but it has shown a similar impact in patients with established as well as those without established cardiovascular disease. And that's some of the exciting portions of this drug. So they all have low risk of hypoglycemia. Some are twice a day, we have once daily, Lixi and liraglutide. Exenatide is once weekly, so is dulaglutide and semaglutide. And they all have varying degrees of weight loss, and probably semaglutide has the most impact on the weight loss per se. And this is just to show you the number of cardiovascular outcome trials that have gone on in the last 10 years or so in these GLP-1 receptor agonists as well as SGLT2 inhibitor classes. And we'll talk about many of them. A recent meta-analysis of the effect of GLP-1 receptor on different populations is shown here. First, when you look at the group with the established atherosclerotic heart disease, an overall effect is favorable, which reduces the adverse events in patients with atherosclerotic heart disease. The two trials which did not show an impact involved drugs, the Exendin and then the exenatide LAR. The reasons for their lack of superiority is thought to be due to the short-acting nature of uh, the one drug, and the other drug, the device was so cumbersome that 30% of the patients did not actually use it. And when you look at the other uh, group, which involved multiple risk factors but did not have established cardiovascular disease, they were not able to show that there is a superior effect. Let's do a case here. It says 43-year-old overweight hypertensive woman is newly diagnosed with type 2 diabetes with an A1C of 8.5%. Which one of the following is the best choice for initial therapy in addition to weight reduction and exercise? So you have metformin, sulfonylurea, glitazone, exenatide, or liraglutide. Both are GLP-1 agonists, and then you have DPP-4 inhibitors such as sitagliptin, saxagliptin, and linagliptin. And if you chose metformin, you would be correct. And the point of this question is, regardless of all the data, the foundational therapy for type 2 diabetes is still metformin, along with comprehensive lifestyle management, including weight management and physical activity. So the consensus recommendation is metformin is the preferred initial glucose-lowering medicine for most people with type 2 diabetes. Now, of course, if they have frank symptoms of hyperglycemia, like polyuria, polydipsia, you will be considering use of insulin at that point. And the reason for this recommendation is its long-standing efficacy, safety, tolerability, and extensive clinical experience. So don't forget metformin, despite all these new medicines data being out. So this is the current algorithm from the American Diabetes Association for approaching the management of type 2 diabetes. The first line of therapy is metformin and comprehensive lifestyle. In patients with indicators of high risk or established heart disease, atherosclerotic cardiovascular disease, CKD, or heart failure, the pathway goes towards GLP-1 and SGLT2. This is what we will be focusing more on today. Next, let's look at a 55-year-old male who has type 2 diabetes, who's had it for 10 years, is on metformin and linagliptin, which is a DPP-4 inhibitor, is here for an office visit. He underwent bypass about 8 months ago. He had an MI prior to that. And in terms of medications, he's on maximum dose of statin, aspirin, and lisinopril for hypertension. So he has morbid obesity, and his most recent A1C was 8.2%. So when it comes to diabetes management, which of these would you go with next? So you have EMPA and DAPA-HF, SGLT2 inhibitors. You have liraglutide and exenatide, which are your GLP-1 agonists, and then insulin glargine. So let's look at some guidelines and data. So if you look at the ADA guidelines, if ASCVD predominates, such as established ASCVD, heart attack or stroke or TIA, bypass, stents, then you would start preferring the GLP-1 receptor agonist with proven cardiovascular benefit. So you have many GLP-1 agonists, like I alluded to earlier. So liraglutide, dula, and semaglutide all have proven superiority, whereas the exenatide and lixisenatide are considered to be non-inferior. So they're safe, but so they don't harm, but they don't necessarily have a superiority data. So if you can't use that, then for whatever reason, or if they're already on a GLP-1, then you might consider an SGLT2 inhibitor with a proven cardiovascular benefit, such as EMPA, CANA, and dapagliflozin, provided the eGFR is adequate. So if you start with the GLP-1, if the A1C still remains high, you could consider adding an SGLT2 inhibitor. Then the other lines of therapy would be, you could add on a DPP-4 if they're not a GLP-1 receptor agonist, basal insulin, so on and so forth. So if you look at some of the data, liraglutide is one of the first GLP-1s to show the cardiovascular benefit in this population. So they looked at liraglutide versus placebo in patients with type 2 diabetes and established cardiovascular disease. This was a large multi-center randomized controlled trial. The primary outcome was the fairly common 3-point MACE, which is the first occurrence of CV death, non-fatal MI, or non-fatal stroke. They showed that liraglutide significantly reduced this 3-point MACE as compared to placebo, and this is what gained its FDA indication to reduce cardiovascular events in patients with type 2 diabetes and heart disease. Not to be outdone, dulaglutide has shown a similar effect. Dulaglutide's effect on cardiovascular composite outcomes similar, 3-point MACE, similar as in a large multi-center randomized controlled trial. The effect separation looks like it starts pretty early on. So dulaglutide significantly lowers the 3-point MACE compared to placebo in patients with type 2 diabetes, cardiovascular disease, as well as no cardiovascular disease. So that's the difference in this trial, is that it not only had patients with established, in fact, a good majority of them did not have established cardiovascular disease. So this is one of the first or only GLP-1 which is shown to reduce cardiovascular events in patients without established, so almost a primary prevention data. And so going back to this case stem, I would prefer a liraglutide choice instead of the other ones, just because it not only has the cardiovascular data, but it can reduce the A1C more robustly than some of the other options, and also help with weight loss. So how does this work? So what are some of the potential mechanisms that mediate the beneficial effects of GLP-1 agonists? We tend to think of the reduction of classical cardiovascular risk factors, such as, of course, the blood glucose, and of course the blood pressure. It does have some diuretic effect, which could help with lowering blood pressure. It also lowers body weight and could help with some of the lipids, and that is one pathway, or the commonly known pathway for cardioprotection. But also, additionally, it could increase myocardial contractility, glucose uptake, increase heart rate, increase ischemia tolerance. And when it comes to the arteries, it could improve endothelial function, decrease arterial stiffness, increase plaque stability, decrease platelet aggregation. So keep in mind that GLP-1 agonist effect can involve more than just glycemic control. It has numerous non-glycemic effects through which it can offer cardiovascular protection. So moving on to SGLT2, just so we are on the same page, SGLT2, this is the sodium glucose-like transporter 2, is responsible for about 90% of reabsorption of the glucose. And SGLT2 inhibitors obviously target this transporter, which results in glucoseuria. We do have an SGLT1, but it does not pick up the slack from SGLT2. So the glucoseuria results in caloric reduction, weight loss, glycemic control. It pulls out fluid, so that helps with the blood pressure. So it has multiple effects. So the currently available SGLT2 inhibitors are, you have CANAGLIFLOZIN, DAPA, EMPA, and ertugliflozin. So CANA, you have 2 different doses, 100 milligrams, which can be bumped up to 300. All of them have indications to improve glycemic control in addition to diet and exercise. But when you look at individual ones, CANAGLIFLOZIN does have indication to reduce risk of the MACE in adults with type 2 diabetes and established cardiovascular disease. In addition, it has the indication to reduce And we'll look at this data a little bit. Reduce the end-stage renal disease, a doubling of serum creatinine. So basically renal outcomes, and also has the indication for hospitalization for heart failure. And dapagliflozin similarly has the um, heart failure indication, not just, in fact, there's new data which shows it doesn't just help with heart failure in patients with diabetes, but also in those without type 2 diabetes. The empagliflozin, its main indication is, in addition to glycemic control, is the risk reduction of risk of cardiovascular death in patients with type 2 diabetes and established cardiovascular disease. Now, this is the last remaining SGLT2 inhibitor, but this most recent trial did not actually show superiority in cardiovascular outcome trials. So all of them have low risk of hypoglycemia, help with weight loss, and they have various degrees of renal adjustments as shown here. You don't want to use it for less than 30. And if it's less than 60, CANAGLIFLOZIN maximum dose is 100 milligrams. And dapagliflozin is not recommended below 45 for patients with type 2 diabetes and heart failure. The main reason being the glycemic effect is lost as of the SGLT2 inhibitors as the GFR lowers. Now, for patients with heart failure per se, you could use dapagliflozin as low as 30. And we'll talk about that too. Empagliflozin, anything less than 45, we don't use. And erdagliflozin, it's anything less than 60, we don't use that. Another case, as a 55-year-old male with type 2 diabetes for 12 years, he's had heart disease and CHF for 12 years. He's on liraglutide and glargine, and he reports recent admission to the hospital for heart failure. So then metformin was stopped and A1C is high. What are the next best steps? We have two SGLT2 inhibitors. We have the mealtime insulin, and we have a choice to switch to a different GLP-1 agonist. Okay, let's look at the current guidelines and data. So ADA recommends choosing going down this pathway when you have patients with heart failure or CKD predominating, especially those with low EF or a GFR between 30 to 60 or a urine albumin creatinine ratio more than 300. You should consider using an SGLT2 with evidence of reducing heart failure and or CKD progression as long as the GFR is adequate. And if you can't use that SGLT2, then only consider GLP-1RA with proven cardiovascular benefit. But keep in mind, in the setting of heart failure, avoid TZD, such as a pioglitazone, and also avoid using DPP-4 such as saxagliptin, and that particularly has been shown to increase hospitalization for heart failure for some unclear reasons. So we already know that empagliflozin, for prior to this trial, we had empagliflozin was one of the first SGLT2 inhibitors to show improvement in cardiovascular outcomes. So we know that empagliflozin can help in patients with type 2 diabetes and established heart disease. So secondary prevention is somewhat decently established. Now, there have been, of course, some safety questions about amputation, stroke, and DKA. Well, what they did with this dapagliflozin was they did a huge trial, 17,000 subjects. But the beauty of this trial was they not only included established patients with established CVD, they also had patients without the established CVD and multiple risk factors, but way more than that CVD. So they got randomized to either 10 milligram DAPA or placebo. So the median follow-up was 4 endpoints. And their primary endpoints was slightly different. They had two primary endpoints. One was a combined CVD and hospitalization for heart failure. They saw robust reductions with dapagliflozin, separation starting way early on. With the MACE, they did not see a significant reduction. So with the primary endpoint was primarily driven by the reduction in hospitalization heart failure, but also significantly you saw 40% reduction in the renal composite outcomes, such as reduction GFR, end-stage renal disease, or renal death. So what do we learn from this trial? It is the largest SGLT2 trial, which included both primary and secondary prevention patients. So it reduced the combined CVD heart failure hospitalization outcome, but neither increased nor decreased the MACE outcomes. So importantly, the reduction in this CVD heart failure outcome was consistent regardless of the baseline ASCVD or heart failure. So it was generally safe and well tolerated. They had the usual side effects of the increased genital infections and slight increase in the euglycemic decay. But more importantly, there was no difference in amputation, stroke, or fracture. They even had some reduction in hypoglycemia. How significant that was is not clear. So again, not to be outdone, we talked about the empagliflozin. So in this population of type 2 diabetics and cardiovascular disease, EMPA, the primary endpoint was definitely reached in terms of the cardiovascular outcomes of MACE, but it also showed reduction in hospitalization for heart failure. So, but these were in population with type 2 diabetes and established heart disease. But the even more exciting trial from a dapagliflozin is this trial, which was done in patients with and without, in fact, mostly without type 2 diabetes. So dapagliflozin showed reduction in hospitalization for heart failure in patients without diabetes and with diabetes. And so that's what earned its indication for heart failure, regardless of their diabetes status. So going back to this patient, the most evidence-driven answer would be, I would say, dapagliflozin, because this patient has heart failure. Ertugliflozin does not have that data, and semaglutide or any GLP-1 does not have that kind of data. And so how does this actually work? So if you look at the diabetes-associated ventricular remodeling, there are a variety of different factors that the SGLT2 inhibitors may target, such as the left ventricular hypertrophy, increased cytokines and inflammation, extracellular matrix remodeling, impaired cardiac metabolism, and cardiomyocyte apoptosis may happen too that it may target. So some of the proposed mechanisms are the prominent one is the improved ventricular loading conditions through reduction in preload due to natriuresis and osmotic diuresis, and afterload due to reduction in blood pressure and vascular function improvement. Also, interestingly, it is thought to, by increasing ketosis, it is thought to provide the heart ketones as a less expensive fuel, and so that improves cardiac metabolism. There's reduction in necrosis and cardiac fibrosis, alteration in inflammatory markers. So when you look at it all together, the SGLT2 inhibitors have moderate benefits on atherosclerotic MACE that is confined to the established. So if you look at MACE outcomes, then maybe established heart disease at ASCVD is where the biggest effect is. But the really interesting effect is on reduction of heart failure. This does not appear to depend on the baseline ASCVD status, prior heart failure, renal function. In fact, doesn't depend on diabetes as well. So the declared TIMI really extended the effect of the heart failure beyond the primary, secondary population. It extended to primary prevention as well, and the DAPA heart failure extended it to the patients without diabetes as well. And next, last case scenario is a 55-year-old male with type 2 diabetes, and for 12 years he had heart disease and CHF for 12 years. He's on liraglutide and insulin glargine. And now it's the similar case, except now the EGFR is 40 and the urine albumin creatinine ratio is 350. So what are the next best steps? Here you have 4 different SGLT2 inhibitors. So what's the evidence? So let's look at CREDENCE, which is the effect of CANAGLIFLOZIN on renal outcomes in type 2 diabetics and nephropathy. And so they compared CANAGLIFLOZIN 100 milligrams to placebo in this population. So the primary outcome was a composite of end-stage renal disease and doubling of serum creatinine or renal or CV death. So what they found that their primary outcome was achieved in both the primary prevention and secondary prevention populations pretty robustly. So in summary, among adults with long-standing type 2 diabetes, proteinuria and hemoglobin A1C 8.3, so SGLT2 inhibitor, the CANAGLIFLOZIN, reduced major cardiovascular events, hospitalizations for heart failure, and renal events in both primary and secondary prevention groups. And so this is the SGLT2 that's been sort of plagued with the amputation and fracture risk, and so this helped solidify that they were not associated with amputation risk or fracture risk. So revisiting our question, CANAGLIFLOZIN certainly has the data to back it up, and I didn't show you the data, but DAPA-HF, they conducted a similar study as CANAGLIFLOZIN in the renal population. So that was the DAPA-CKD, and that showed a very similar benefit. So in this population, I would say both CANA and DAPA are both applicable. In fact, the EMPA studies are ongoing, so and which I believe would be helpful as well. So eventually, all three of them will be relevant to this population, this person. So how do the SGLT2 inhibitors help here? So as you know, diabetes is associated with afferent arteriolar dilatation. This leads to high intraglomerular pressure and hyperfiltration. So ongoing barrel trauma to the glomerulus, this may lead to the proteinuria. Now, SGLT2 inhibitors through tubuloglomerular feedback, they promote afferent arteriolar vasoconstriction. So this serves as a mechanism to reduce the intraglomerular hypertension and provide nephroprotection. So some of the conclusions based on the cardiovascular outcome trials, keep in mind these are data not from head-to-head trials. So if you look at GLP-1 agonists, they reduce MACE outcomes for existing cardiovascular. That is one of the robust effects, and potentially also multiple risk factor population, especially as proven by one GLP-1, that's the receptor agonist, that's the Liraglutide. I didn't present all of the data due to lack of time, but they may have a greater impact on stroke risk than MI, and they may have some protective effect on renal outcomes as well. Now, the SGLT2 inhibitors, for sure, they help with reduction of MACE outcomes in existing CVD. The reduction in the primary prevention population is not clear. But the more exciting effect is the reduction of hospitalizations for heart failure and the protective effect on the renal outcomes. And that's even more distinguishing from the GLP-1 agonist. This is a summary of many of the drugs we discussed in GLP-1 RA class and also the SGLT2 inhibitor class, and they have varied effects. As you can see, the predominant effect is in the type 2 diabetic population with established cardiovascular disease. So secondary prevention seems to be a common theme in both the GLP-1 RA as well as the SGLT2 inhibitors, and there's only one study with the primary prevention data with Liraglutide. But in terms of the heart failure and CKD, that's where the SGLT2 inhibitors really dominate, and especially with the DAPA has shown data in heart failure and CKD populations even without diabetes also. So in summary, consider the presence or absence of ASCVD, CKD, and heart failure. Always start with metformin if possible, untolerated. In those with ASCVD, start with the preferred is a GLP-1 RA with a proven benefit. In those with heart failure, go with the SGLT2 inhibitor if GFR is permitting. In those with CKD, again, GFR permitting, go with the SGLT2 inhibitors, and always choose some agents those are proven or have proven benefits.